Dr. Howell. I hope everybody got the notes out of that one. If you have any questions, don't forget to write them down. We have one more presentation before the Q&A, so we'll be around to pick up those questions right after Dr. White speaks. So Dr. White is with the Department of Radiology at the Medical College of Wisconsin, where she's Associate Dean, Vice Chair, and a Professor. She's here today to speak to us about interventional therapies for liver metastases. So please welcome Dr. White.
How are you guys today? Good? It's beautiful outside. The last time I was in Iowa, I was interviewing actually for residency, and I landed in this little plane in Iowa City, and there's like ice storm. You all know these ice storms in Iowa. I didn't know what this was. So the plane lands and we like don't really stop. We like slide across, and I go get a rental car and I have to drive to the city where the university is, where the hospital is. There were cars all in the ditch. So today, last night when I drove in, I was like, oh, thank goodness, there's no ice storm. So I'm very happy to be here, not during an ice storm. So my name is Sarah White. I am an interventional radiologist, as Bob said, and we're going to talk to you about some interventional therapies for liver metastases. So who's heard of an interventional radiologist? Have you ever heard of this? Oh, some hands. So you all must have seen one of us. Nobody's ever heard of us, right? And then when they find us, they're like, we love you and you're going to be our doctor for life. Whenever I'm on the plane and people say, can you be my doctor? I say, no, I don't think so. You don't want me. You really don't. I've given a lot of talks for Bob and Marianne, and I really love giving these talks, although I will say it's some of the most intimidating talks I ever give. I get to treat patients and I get to leave that at home, and you all have to live with this all day, every day, so you are, in fact, the experts. And so you all teach me every time I come here about what it means to have disease and live with it day in and day out. When we talk about toxicities, we all say, well, these are the toxicities. It's not a toxicity, it's your life and how it disrupts your life. So the goal of interventional radiology is really to prolong your life. We're not curative in any stretch of the word. What I do is not cure, it's palliation. What does palliation mean? It means to keep you alive as long as we can and not affect your quality of life. So that's my goal when I do any of my therapies. So what are the therapies, you say? So I'm just going to give you, start with 3 of my patients that I've seen over the years. This patient with the coronal view, so this big picture on the image left is a patient that came in. He was a dad. He had a young kid. He was 8-year-old, a little boy. And he came in and he had just lost so much weight. He was so thin. And he said, Dr. White, no matter what I eat, I just can't keep any weight on. You can see his liver is chock full. That picture you should be able to see his intestines. You should be able to see his other organs, and all you're seeing is his liver because his liver is so enlarged. He has multifocal metastatic neuroendocrine. So he came to me. We did what we do, right? We did a biopsy, we staged him, and we decided to embark on liver-directed therapy, we'll go through what that is, and I'll show you how he turned out. This other patient, the picture up on the top one, this is a guy that was from England, and he'd always sort of had an upset stomach. He just had a sensitive stomach for a long time, about 30 years. And he had diarrhea, and he got hot a lot. He worked in a factory and actually lost his arm, and so he retired and got disability and moved to the United States, immigrated to the United States. He was married, and he had such terrible diarrhea, he couldn't even walk his dog. He had 2 little Shelties, and they couldn't even go around the block because he had such bad, profound diarrhea. And so he was sort of bedbound. And so his doctor finally said, is Dr. White, is there something you can do? So he got in a car, traveled 2 hours south to Milwaukee to see me, had to stop, every couple miles to go to the bathroom. But ultimately, we were able to treat him. And the bottom one is a young guy. He was actually snowmobiling. Okay, he was out with his family, and he was snowmobiling, and he crashed the snowmobile, which is why my children will never get on one, just saying. And crashed the snowmobile, and incidentally, was found to have metastatic neuroendocrine. Okay, he also said, well, I kind of had an upset stomach for a while. I just thought I was sensitive to certain foods. So this is sort of the smoldering. We didn't really know what was going on. Patients are sort of say, oh, I have a sensitive stomach, and that's just that. And maybe didn't notice that they had therapies. So what are the liver-directed therapies? I always say it's like the alphabet soup. When you come to IR, we'll say taste, tear, ablation, IRE. Like, what are you talking about? And many of the referring doctors will just send them to Sarah and say, Sarah, just take care of this. I don't know what you're going to do. You're going to have these big words. just take care of them. And that's what ultimately we do. I have a picture of Dr. Yamada. He was one of the first in the world to ever inject something via an artery into the liver to treat tumors. And that was in 1977 in Japan. That's his picture there. We almost had the fortune of meeting him. He was coming over to a conference, and then guess what hit? COVID. And he was too scared to get on the plane, so we didn't get to meet him. So I'll go through the alphabet soup. So TACE, I think you heard Dr. Howe say TACE. Transarterial means we're going to go across the artery. Chemo means chemotherapy, right? Those drugs that we use. Embolization means I'm putting something in your artery that's going to block it off. I'm going to prevent the blood from going beyond the thing that I'm blocking it off. Think of it a cork. I'm putting a cork in something so nothing can get beyond that. Typically, we will either use two types of things when we do transarterial chemoembolization. One, we mix drug with oil, and we'll go through why we do that. And the other is we have these little beads. That picture up there with the little vial with the little red dots, those are beads, and we just put drug and lock it on to the bead. So that's when we call drug-eluting bead transarterial chemoembolization. Transarterial embolization, now we're losing the word chemo, so that's when we just block off the blood supply instead of infusing chemotherapy with it. Dr. Howe also talked about transarterial radioembolization. So transarterial just means I'm going through the artery. Radio means I'm putting something that's radioactive that's going to kill tumors. Embolization, block off blood vessel. And so those are all the things that we do if we're coming from inside of the artery. Now, Dr. Howe talked about ablation. Now, again, there's an alphabet soup of ablation. I'm a history person, as you could probably tell by the first slide, so that's Dr. Lavrahi, Tito Lavrahi. He's from Italy, and this is the first ablation he ever did in 1982. Can you imagine if the accreditation boards came to my hospital and saw me without a mask, hat, I just smeared some betadine on and rammed something in somebody. So that's Tito doing the first liver ablation. The first ablation was done by his partner, Dr. Solbiati, in his thyroid. Not his thyroid, a thyroid. But Dr. Lavrahi did the first liver ablation in the world in 1982. And then this is the charter members. Those are all the guys that did the first ablations in the world. And that's a picture of what they did. So what is the alphabet soup? So PEI, percutaneous ethanol injection. That's what Dr. Lavrahi's doing in that picture. So before we had heat-based modalities where we'd stick a needle in and actually burn things, we would stick a needle in and we would chemically ablate. So we'd put alcohol and just kill the tumor. Radiofrequency ablation is where we stick a probe in, and it's just a frequency of wave that we use. It was not as robust and strong, so we switched to microwave, just like the same microwave we use to heat up our food. Microwave is just a stronger ability to heat things. And then IRE is irreversible electroporation. We usually put two probes in, although now we have one probe, and it basically electrocutes the cells. So it's a little bit thermal, but really it's just a way to snap or shock the cells. And when we shock the cells, what happens is they break open their walls. When they break open their walls, they can't live because either fluid comes in or fluid goes out. And so that's electroporation. Why would we use any of those? It has to do, it's very complicated to how we choose. It doesn't matter. The bottom line is we're killing tumors by sticking something in from the outside. Again, Dr. Howe said, who would be an ablation candidate? You have to have just a few areas of disease, and I'll show you a case of where we did an ablation. So again, I think we sort of talked about this at the beginning. The goals of liver-directed therapy are, one, I want to make sure that we can debulk the tumor. So I want to make sure that you have fewer tumors in your liver, because really my goal is to prevent progression of disease, but I also want to control your symptoms. But in doing that, what I can't do and I don't want to do and is unsafe for me to do is kill your normal liver. So I have to be very careful about what I'm infusing so that I'm doing the bad thing to the tumor, but the rest of the liver I'm keeping alive so that you can go on to have more therapies, because that's really ultimately what we'll need to do. Am I able to get you to surgery? Can I get you to Dr. Howe and his magic that he does in the OR? Or am I not able to? And again, the other thought is, if you have disease that's stable everywhere else in your body, but you've got disease that's progressing in your liver, so you have something in your bone, but it's kind of been there and it's not doing anything, but the stuff in your liver is getting bigger and bigger. So the systemic therapy, maybe those injections you're getting, are doing its job. It's just the liver's being a little punky and not pretending, it's not playing nice. Can I just treat the liver stuff so that you can stay on the same regimen? Because we know the longer you can stay on one drug, the longer your overall survival is. Because as we start to go down the line, your cells start to be, those cancer cells start to be smarter and smarter, and they say, oh, I know how to get rid of that chemo. Oh, there's another one, and I already know that one, I can get rid of this one. So can I keep you on that first one longer? So can I treat locally the disease that's being bad while you're able to get the shots or something else for everything else? And again, do no harm is what I always say. I don't want to hurt you. I want to make sure that we're killing cells, keeping your quality of life good, keeping you doing what you need to be doing, which is not worrying about your disease, that's our job, and making sure that your liver is still functioning in a way that you can go on to do whatever you need to do, which is maybe systemic therapy. So I bring this slide up as sort of a way to introduce that the liver is one of the most magical organs in the body. Did everyone know this? Everyone thinks your heart is the center of your soul, right? It's not, it's your liver. Do you know why? Because if you don't have a heart, right, you can have a mechanical device, right? Dick Cheney had the LVAD, remember that? Right. So you have this device that can be outside of your body. You don't have anything for the liver, right? If your kidneys fail, we can put you on dialysis. But for your liver, we have nothing, okay? But the other magical thing about your liver is your liver has 2 blood supplies. So cool, okay? So the liver has the blood that comes from the intestine up to the liver. So the liver's job is to filter out toxicities. So we all just had our little snack, and when we ate things, we ate good things, but we also ate toxic things, right? And so what we do, the body has created a network of blood vessels that go from the intestine to the liver. And the reason is we ate something. All that stuff gets filtered into the blood. It gets absorbed into the blood. That blood gets taken through these mesenteric vessels or the portal system. It goes to the liver filters it out, and then it goes back to the regular veins to the heart and throughout the rest of the body. So the liver is the first stop for all of these bad things that we eat, okay? The liver really likes that blood. It's got sugar in it, it's got protein, it's got all this good stuff in it. So the liver gets about 75% of its blood supply from the portal vein, okay? It doesn't have oxygen, but it has all the good stuff. Now the artery, the heart's pumping, right, and bringing all that good oxygenated blood in. The liver's like, I kind of need that, but not really. So I'll only take 25% of that, really, or a third of the blood supply to the liver is needed from the heart, okay? And so because we have this cool dynamic of blood coming from the intestine, blood coming from the heart, if I knock out the artery, the liver's like, don't really care. And why is that important? Because tumors don't like dirty blood. They're like, that's toxins, it doesn't have any oxygen. And tumors really, really like oxygen, right? That's what they need to grow. So tumors will send out a signal and say, listen, I need some blood. I need some oxygen. And the body will bring more blood supply. So more arteries come in. And so what happens is the tumors get 90% of their blood supply from the artery and 10% from the portal vein. So if I were to embolize, I talked about embolizing, if I were to cork up the artery, right, in the liver, the tumor would die. So the tumor's like, look, I don't have any oxygen, I'm dead. Whereas the liver would be like, that's okay, I'll just use this other blood I have behind. So that's the portal system. So on this picture, what we're talking about, what I'm showing you here is that most of it's blue, right? And then there's this little red stuff. And that little red stuff is the artery. So the majority of the blood flow is coming in from the portal vein and not necessarily from the hepatic artery. So when we embolize something, I talked about there's 2 different modalities we can use when we do transarterial chemoembolization. So one is where we put beads. So the picture closest to me is we have those little teeny tiny beads. They're covered in drug. We infuse them in, they go into the artery, and you can see that they block off the blood supply and the tumor should die. But you can see there's those weird connections, those sort of arms that are coming on the other side, those arms coming on the other side of the portal vein. There's 10% of the blood supply that's coming from the other side, that dirty blood. The tumors are like, well, I can't really get that much oxygenated blood, I'll take some of this dirty blood. So when we do chemoembolization, when I mix the drug with oil, that oil is a liquid, it goes and it sludges up, and it can cross those little communications and into those sort of finger-like projections from the portal vein, and so we're able to get a deeper embolization, we think. And so the tumor is we are able to eradicate the tumor in a better way, a more effective way, because we can get the portal vein side and we can get the hepatic artery side. Now, I will show you the data behind this, that this actually is in fact the case. But first we'll go through what we need when we do the chemo emulsion. So what you're seeing here is that vial on the top is the oil, and the vial on the side is the drug. Okay, so I mix this on the table, and I make this every day. So what are the components when I do a chemoembolization? I have a drug. The drugs that we use are listed there in the United States. We use triple drugs. We use doxorubicin, mitomycin, and cisplatin. Okay, it doesn't matter if you go somewhere else in the world. You may not have that complement. That's just what we use here. We use oil, and we use an embolic, so the bead. So why do we need those three components? So I always explain it to my patients this way. So if you have coffee, right, and you spill it, what happens? It just sort of, and you have a hose, it washes away, right? So now imagine I'm injecting a drug that's a liquid into the liver. The hose is the artery behind it. It goes into the liver, it washes away. It's not going to stay in the tumor, really. What I want is for that drug to stay in the tumor. So now imagine I spill some olive oil, and I have the hose. What happens if you put the hose on the olive oil? Right? It's a little slower, right? It beads up. But eventually, if you keep the hose on, the beads disperse and the oil's gone. So now, let's say I spill the oil and I turn the hose off. Well, that oil's going to stay there for a long time, right? It's going to be there for a long, long time. And so that's the idea with the chemoemulsion. I mix the oil with the drug, so I get that thick, sludgy consistency. I sludge it into the blood vessels, and then I turn off the artery. I turn off the blood that's going to wash it away by putting teeny tiny little plugs in, and those plugs are embolic beads. There are a bunch of them that I can use. It doesn't matter. Again, this is sort of the technical aspect of it, but that's essentially what I'm doing is I'm infusing this oil and then I'm blocking it off, turning the hose off so it has to sit there and block off the blood supply to the tumor. This is what it looks like when we infuse it because it's oil going into blood, right? It's sort of what happens when you put oil into water. It's like salad dressing, right? You get those little beads. So it looks like, I always teach my fellows, it looks like the ants marching. The ants are marching in to go kill the tumors, and that's exactly what it looks like when we infuse it. So what about the beads? We talked about the beads. What do they look like? So the beads are connected to a drug versus an ionic bond. So that's a chemical compound, has a negative charge, like a magnet, right? A negative charge and a positive charge, and we put them together into a bead and they stick on, okay? And that's all drug-eluting beads are. They have these little embolic, right? The little corks that we're putting in, they're bound very tightly just because of this positive negative charge, and we infuse them. These are just really cool pictures. When we look under a microscope, we look really high view of what the way they look like, and you can see the little notches. It sort of looks, I think, like the lunar surface, but that's what they look like on the surface of the bead, and that's when we would infuse in. And we typically here in the United States, if we're going to do drug-eluting bead, we will load doxorubicin. That's our drug of choice for many of the tumors. We can load other drugs, but again, the drug has to be able to have that charge so it can stick to the bead. We've tried many, many drugs, and many of them don't stick to the bead very effectively, so that can limit our ability to give beads. This is what it looks like. This vial comes from pharmacy. They basically just put it on a rocker and they rock it for 2 hours, and that's how those ionic bonds happen. It's not magic, just like the magnet. And then we infuse it in. So radioembolization is the same concept, okay? It's those little teeny tiny beads. But now, instead of a drug, we've put a radioactive material. When we do radioactive material today, now there are many more platforms coming down the pipeline that are just being tested, we use yttrium. So yttrium is just a radio isotope. They actually mine it in South Africa. We make these teeny tiny little glass beads in the United States. We send them up to Canada. They get put together. I'm just talking about one of the platforms. They get put together, and now we have these little specks that are like dust. You can barely see them, okay? They're 40 microns, and they carry this radioactivity directly into the liver. Now, the beauty of that is that they can get deep into the tissue. When you do SBRT or radiation where you have to go and lay down, the radiation has to come from outside and come in. What I'm doing is I'm infusing the little radiation on the inside, okay? So when the radiation comes from the outside, it has to come from the outside. Now it has to go through the skin, the bone. If it's not the bone, it has to go through the soft tissues. And then what does it come out the other side? So if I'm coming this way, I might hit the kidney. If I come this way, it might be the spine. So sometimes SBRT can be limited, so the radiation from the outside can be limited by the toxicities of the organs around it. And the liver's a big space, and it's in sort of a bad place, right? We talked about the pancreas is right there, and the gallbladder, and the bile ducts, and it can be very challenging for them to get an effective dose, especially when you have so many lesions. These beads go where they go, not because they're smart, they go because there's more blood flow to tumors. So it's brilliant, right? These beads just go where the blood flow goes. Their blood flow is going to the tumors because the tumors are asking for more blood. and so that's how the little beads travel there. The radioactivity only travels about 1 centimeter, so it's a beta emitter, that's what it's called. That's what kind of radioactivity it emits. So even if the stomach is lying on top of the liver, you're not going to get toxicity to the liver. Now, if a bead were to go into the blood vessel that supplies the stomach, you could. But for the most part, we're able to give higher doses by a huge magnitude because it's going directly to the liver and directly to the tumor. Now, again, we'll talk about, is that safe? What about the normal liver, right? Because the tumor is living around the normal liver. Is there going to be damage to the normal liver? And we'll talk about it. So that's the sort of the alphabet soup. That's the theory behind what we do, and those are the agents that we use. So the question is, do I or should I even think about liver-directed therapy if I have liver metastasis? Or should I go on and get systemic therapy? And this is sort of the age-old question, do I do systemic chemotherapy or do I do something site-selective to this? So this was a registry that they looked at patients in California over a long period of time, and they looked at 150 patients that had metastatic neuroendocrine, and 87 of them had systemic therapy, and a fewer majority, about 70 of those patients, had liver-directed therapy. And they did an analysis, and they said, okay, who had a better prognosis? Who lived longer? Which patients lived longer? Did they need systemic? Did liver-directed therapy augment them at all? And what they found is that if you had liver-directed therapy, your survival was better. So these are Kaplan-Meier curves, okay? Kaplan-Meier curves are what the be-all and end-all to cancer care, okay? Do you see the line at the top? You want to be on the top line, because what the top line means is you live for a long time. When the line goes like this, and it starts heading down, downward trajectory is just like, it's not good, right? Downward trajectory means you're not surviving as long. So the top line is those that have some sort of therapy to their liver. The bottom line is if they just got systemic therapy alone. Okay, so median overall survival, better when you have liver-directed therapy folded in. And then when you look at overall survival, it's just how long did you live? And then we have to say, well, did you die of something else? Maybe you died of a heart attack, right? So what happens when we're just looking at death from the cancer? And you can see we're still on that top line if you fold in liver-directed therapy, if you have liver metastases. So again, you want to be on that top line. You don't want to be on any of those bottom lines. You don't want your curve this way. You want your curve flat and straight and high, okay? So that's what a Kaplan-Meier curve is. So then what about the guidelines? Like cancer doctors always are looking at guidelines. They'll say, per guidelines, this is what we're supposed to do. So these are the guidelines. The NCCN guideline includes an option for hepatic-directed therapy in hepatic dominant disease. So we're there. So medical oncologists should be thinking about this. If there's disease in your liver, we should really be thinking about adding this in, because we do have data to support that you will live longer if you have some sort of targeted therapy. Here are the actual guidelines that say hepatic arterial embolization, including bland, chemo, or radioembolization, and then thermal ablation, as we talked about. Now, the guidelines are a little bit funny, right? You think they would tell you which one. Because if you look at the guidelines, many of them will say this chemo, at this stage, and that stage. But here they're like, we don't really know. So we wanted to answer that question, and so we looked at all of our data. We've been looking at our data for a long time. Do we do bland, right, where we just infuse the corks, or do we need the chemo emulsion? And what we found is that 2-year overall survival, and here what we're looking at is, see that line in the middle, and then that big black triangle at the end? The big black triangle at the bottom tells you sort of what all of the studies have shown. And what we see is that the 1-year survival, the 2-year survival, you're so close to that middle line. And if you're close to that middle line and it's not one way or the other way, that means that there's probably no difference. Okay, so these studies have showed us maybe there's a little bit better survival with bland embolization, and then the second one says at 2 years, maybe a little bit, and then at 5 years, maybe a little bit with chemo embolization. So this data sort of tells you maybe it doesn't really matter between that. When we look at chemo embolization versus radioembolization, again, we're looking at the complications, and we're looking at the ability to control disease and how long patients go before they progress. And what we're finding here is they're different, but they're not statistically significantly different. So when we look to say how many patients do we need and does this really matter, the numbers look different, but when we put it through the statistical models, it shows that there's probably not a difference in survival. So which one should you get? I don't know the right answer, but maybe. And this here again is another group that looked at this and they said, can we compare them? And what they found is that we don't know the answer to this. Both of them are good therapies. It's probably just a matter of which your doctor prefers and what is the most appropriate for you. We did a big retrospective, so all of the interventional radiology groups that have big academic centers that treat a lot of patients like you all got together and said, let's try to answer this retrospectively, right? Can we answer this question? And so we looked at patients that underwent bland, chemoembolization, and radioembolization, and we really didn't have enough people that were treated with drug-eluting bead. And what we found is that median overall survival and hepatic progression-free survival, so how fast it was that the disease progressed in your liver, it didn't really matter, right? There was no difference among any of the different therapies that we put into your liver. So then really, how do we decide? Which one should we do? Because it seems like, well, it doesn't really matter, so what do I do? So now we looked at how does it affect your liver? Okay, so is one worse for your liver? Is one worse for your survival? Does one make you feel bad? And what we found is that when we did drug-eluting bead, and I told you that slide before, when we put all of our data together, there weren't a lot of patients doing, or a lot of doctors doing that one with the drugs coded to the bead, because what we found is when we looked at our data and we compared things, that patients that got those beads put in were having higher toxicities. And so what does that toxicity look like? In these studies, what it looked like is that the liver would get ischemic, meaning the liver would die an infarct, so you have a part of your liver that's dead, or patients were getting biomas. So the tumor, instead of just dying, would turn into this bile-filled pocket. And so we all, when this data came out, and this data is really old, 2012, when this data came out, we said, we're not doing beads anymore. We don't want patients to have death to the liver. And a biloma, though it's only a collection of bile, it's just this little pocket of fluid, we don't really care, but if it gets infected, it does matter. So we stopped doing this. Most of the big academic centers stopped doing drug-eluting bead because we thought, yeah, it's not prospective, right? We're not studying it prospectively. But when we're doing this therapy for patients, we're seeing a bad outcome. We don't like that. So can we prove that? And so what we did is we got together, and this took us about 15 years to get this together. So we decided to study this prospectively, meaning we're going to look at patients, we're going to randomize them to all of the different therapies, and we're going to follow them forward to say which one is worse, which one is better. Because we didn't know. We sort of had a feeling, but we didn't know. So this is the RETNet study. So it's randomized embolization trial for neuroendocrine tumor. And so we randomized patients to get bland, just the corks, drug-eluting bead, the cork with drug, and then the chemoemulsion, which is where we had the oil mixed with drug. And there were 3 arms. There were supposed to be 60 patients in each. And so what the FDA does when you do these big trials is they do a safety analysis very early. So after the first 30 patients, 10 in each arm, they stopped the trial and they said, okay, let's look at the data and let's see what happened. And so when we did that, whoops, look what happened. The Data Safety Monitoring Committee, the board, said, you cannot do drug-eluting bead. So what we had thought in the past and what our old data had told us is that you have significant toxicity from those beads bared out in 10 patients, okay? So they closed the arm. The FDA said you cannot continue with the drug-eluting bead arm. You can only do the corks and the chemoemulsion. Those are the only 2 we're gonna let you move forward with. And so that is what the trial has done. The trial is now closed to enrollment, and we should have answers very soon. COVID, of course, hit in the middle of this trial, so some of the data is still coming in, but very soon we will be able to answer the question between should we use the bland embolization or should we use the chemoemulsion, and those answers are still forthcoming. So what about radioembolization? So I sort of talked about should you use bland or chemoembolization. That question will be answered. So what about toxicity when you have radioembolization? So I just talked about these great little beads and they go to the tumor. Well, they sort of go to the liver too, right? I mean, I'm injecting them into the artery that's in your liver. And so is there a chance that I could cause your liver to fail because of the dose that's going to your normal liver? And what we found when we did this retrospective study, again, looking back at all of our patients with metastatic neuroendocrine, is that 3% of patients went on to have liver damage, liver failure due to radiation, 14% of those versus 3% that underwent chemoembolization. So what we found is that there's a higher rate of this toxicity from the radiation when you give radiation, a lower rate when you do chemoembolization. So now what do? Do we do the radiation? Do we do the chemoembolization? So in our practice, unless there's a compelling reason for us to do radioembolization, we will start with chemoembolization. I have a much easier time saying to you, there's only a 4% chance that I'm going to make your liver fail in the long run, as opposed to 14. That's a big number for me when I know that things have to go on. Many, many studies have been done looking at this with even higher rates. So 20% of patients had REILD, which is radiation-induced liver disease, because of the toxicities affected by the Y90. So you can do Y90, it's a great therapy. You just have to be careful, and you just have to do it in the appropriate patient population, okay? Here's another study looking at an even higher number of patients that went on to get toxicity. And so our biggest experience with Y90 is patients that have colorectal liver metastasis or patients that have primary liver cancer. And we treat them, and we're very aggressive. But those patients don't live, as Dr. Howe talked about, this is a chronic disease, right? You guys live for a long, long time. And so over a long, long period of time, we're starting to understand, or I should say back then, we were starting to understand that you have to be very careful about who you give these therapies to, because we don't want to cause damage. We have to preserve your liver function. And so when you find your interventional radiologist and they say, let's do a Y90, you got to have us talk. What is my chance of long-term sequela of this? Because I don't want you to cure my disease and then have my liver fail because of the therapy that I got. Again, here's another one. 5% of patients died because of liver toxicity. Not because of their tumor, because of liver toxicity related to the therapy that we gave them. So who's a candidate? So I talked about the good, I talked about the bad. How do you know if you're a candidate? So the things that we consider are, number one, the patient. When you walk in the door, what is your functional status? Can you walk around? Can you talk? Are you able to take care of yourself? Or can you not walk your dog around the block? How tired are you on a daily basis, and what does that look like? So we look at a couple of things. We look at your performance status. We look at the tumor. What's happening with the tumor? How many do you have, and where are they? There's a lot that goes into what the tumor looks like. So performance status is just how you're doing. Are you fully active? Are you able to do what you need to do? Are you interacting, or are you sleeping all day? Because if you're sleeping all day and then I do something to your liver that's going to make you not feel good, right? Any therapy, systemic therapy, surgery, any therapy, if you're already run down and then I do something to really gut punch you, you're not going to recover from that. And so we really look at this. This is a better predictor of survival than anything else I've ever found, and the data has shown. So if you're a 0, you're fully active, and next week or next month when I see you, now you're like, gosh, I'm really tired all the time. You may be a 1, right? So you were a 0 and a 1. I'll treat a 1 any day of the week. But boy, if that slope is fast, I'm gonna put the brakes on a little bit and say, let's figure this out. And you're like, no, it's just because I'm having pain. Nah, it's just because I can't sleep at night. I'm gonna pump the brakes and say, whoa. Let's figure out what's going on. Let's get you feeling better. Let's see if we can get your energy better, because I'm going to gut punch you, and you need to be able to come back from that. So this is very important. I spend a lot of time with my patients understanding. And when you come see me as my patient, I'm not going to say, so how's your performance status? Did you eat today? What'd you do yesterday? And I know one of them came in and she had just rescued a raccoon. Who knew? So her performance status was very good, and I felt comfortable treating her. But here again, what does it look like for survival? And what we see is that patients that have worse survivals or worse performance status have a worse survival. Okay, they're not doing as well, and that's borne out in the data. What about your hepatic reserve? So your liver has to be functioning for me to be able to treat it. So your energy's great, I feel great, but your liver's like, ooh, I'm not really working and I can't really handle it. Saw a patient just on Tuesday who was doing great. He was, granddad, and he was out, he had quarter horses, and he was out doing the horses, but his liver just wasn't working. His total bilirubin was 5, he was jaundiced, his liver was just telling us it's not working well. Boy, I can go in there because his performance status is good. I beat up that liver's gonna fail, okay? So we have to be very careful. Performance status is good. How is your liver functioning? Can I beat up your liver and your liver survive it? Now, Dr. Howe talked about you can have a lot of replacement of your liver. He had more than 75% of his liver replaced with tumor, okay? That's too much. You can live on about 25% of your liver, but when it goes beyond that number, your liver starts to say, whoa, I can't handle this. And so if I were to do something that's toxic to your liver, maybe only 4%, your liver will ultimately fail. So we have to be very careful about what is your liver doing on a daily basis. The Child's Pew is just the score that we use, but ultimately what this shows is that, again, survival really is based on how is your liver functioning. And again, here's that Kaplan-Meier curve, right? You want to be on the top line. That top line is people that have good liver function. That bottom line is patients that have not good liver function. So what about these, can we combine therapies, right? This PRRT we talked about, liver-directed therapy, and what happens if we combine these therapies? I can show you lots of data that it's probably safe, but what I've highlighted here is that if you've had a prior liver-directed therapy and go on to get PRRT, or the reverse of that, it doesn't affect your liver function. Okay, so for now, we think it's okay, and we don't know the order in which you should do it, but we think it's okay. And at the bottom here, to date, there is no evidence, again, the NCCN guidelines, against the safety for putting them together. So can you have both of them? There's no compelling data to say that it's unsafe. If you've had a prior, Dr. Howe talked about all these surgeries you could have. If you've had a prior Whipple, if you've had a gallstone, if you've had some interrogation of your biliary tree, you are a very high risk of developing an abscess if you go on to get chemoembolization, okay? There's a 25% mortality. So in these patients, we really hold back and say, not necessarily. We did a big study, and again, it pooled our data, and what we found is that if you have Y90, it's probably safer, so at 8% risk of developing infection. But again, if you've had a Whipple or some other surgery or manipulation of your bile ducts, we have to sort of pump the brakes a little bit and say, okay, does this make sense? So then we look at the tumor, right? I think Dr. Howe showed a graph just like this. That Kaplan-Meier curve way at the top, what does that mean? It means that you're a low grade, right? As your grades go up, your survival decreases. And so what does that mean for me? It means that I may offer you a Y90 if you're a grade 3, as opposed to a grade 2, as opposed to a grade 1, because I know I have to kick it up higher, but I know that I don't have to keep your liver along quite as long, your liver function quite as long. So it's really going to change how I pick things. Here again is by grade. And then we think about an IR in radiology, the vascularity. I talked about how much blood is going to that tumor. And what we found out is that if there's a lot of blood, and what that looks like on imaging is white spots. So that picture all the way in the left, see that little white spots? Those are really hypervascular. That means there's a lot of blood going there. Those patients tend to do better. Why does that happen? Right, because the beads get there, right? Because the blood brings the beads to the tumor. So vascularity is really important. Not a lot of things that we think about, but things I think about every day. And tumor vascularity, when we actually look, right, do the beads get there? This is a tumor that we cut in half, and see those little black dots? Those little black dots are where the bead went. So the beads don't go uniformly through the tumor. The question is, can I get them enough to kill the adjacent cells? And this is just sort of a picture of how hot the areas are around the tumor, and is it hot enough to kill it? And what we found is over the years that we are getting smarter and smarter about how hot we get tumors, and so we're ultimately able to kill the tumor without causing damage to the surrounding tumor. So let's go back to my patient, right? That young guy, 20-pound weight loss, and this is what he looked like. This was a scan, right? Everyone knows that black dots are bad. This is a dotatate scan. He had extensive osseous and pulmonary mets, and he had liver mets. And his father-in-law was a surgeon, and he said, he's dying before my eyes, okay? This is what his initial MRI looked like. I told you this before. You can't even see any of the other organs. It's all liver tumors. We went on to do a Y90. So the reason we did this is he was in an extremely catabolic state. And so we went on and we did a bilobar. I treated both lobes of the liver. The patient recovered 2 weeks after. And then he was initiated on chemotherapy. These are just follow-up scans. You can see the tumors are starting to shrink away. And this is what he looked like 5 years later. Okay, so we got him from, he looked like death who arrived on my doorstep. And 5 years later, he looks like this. I have now seen him again. It's now been 7 years. He has disease progression in his liver, but his son is now graduating from high school. So we got him to his son's graduation, and he's still working. He's still contributing meaningfully. And we actually did another Y90 all these years later. So he's had all the gamut of therapies, right? I'm not saying it's the Y90 is the only thing that did it, but certainly you can see that we had a dramatic impact. Look at his liver. You can actually see the other organs in his body, right? So we can really have an impact. We had to be very careful about how we treated him, and had obviously multidisciplinary care involved. Here's patient 2. This is a snowmobile accident. This is what he looked like on initial presentation, right? He just had those disease in the back. We went on and treated him. He underwent chemoembolization, which is that emulsion that I put in, right? Young guy, I know he's going to live a long time. We do MRIs because MRIs are more sensitive, and Dr. Howe talked about these lesions that you can't see. I exclusively do MRI because they're easy to see. And you can see now he's got all of these little teeny tiny little spots peppered throughout his liver, small multifocal mets, but he didn't have anything outside of the liver. So he ultimately got a liver transplant. Okay, this young guy went on to get a liver transplant. He had had TACEs before that, and his explanted tumor, or his liver, they found that he had a Ki-67 of 3%, so he was a grade 2 on explant. He had some disease in the lymph nodes in his hilum. And 6 years post, 9 years after his diagnosis, you can see that he's got something in his shoulder. He developed a met in his shoulder. Okay, there it is. So what did I do? I ablated it. So cool, right? I stuck a needle in his bone, ablated the tumor, and so we were able to treat him. He is now back on systemic therapy because he obviously has metastatic disease. I'm not saying I cured him, but certainly we're able to, the reason we ablated it is he had pain. So this is my 53-year-old, right, that had the flushing and diarrhea and was from England, and he looked terrible. When he came in, couldn't walk his dog around the street. He had this big central tumor. Now, not what the other pictures look like, right, all those little scattered disease. He had this big central tumor. It was causing obstruction of his bile duct. And so I went in and I did chemoembolization, trying to sort of retract that tumor and make it smaller. He was able to walk his dog around the block. He actually went to Walmart for the first time in like years. He was like, I got to go to Walmart. I'm like, that's great. Did you buy something cool? He said he felt better than he had in the past 20 years. And his chromogranin A, which I know is a terrible marker, but we used it back there, fell from 2,800 to 700. But because he had perceived that he felt sick after the therapy, he's like, I don't want you to touch me for a little bit. I'm going to walk my dog, but I don't really want to go through this again because you do get a post-embolization syndrome, which is like a flu-like syndrome for a week or two. And so what happened is over 3 months, he sort of went on and his chromogranin started to rise again. And he developed left-sided biliary ductal dilatation. So the bile duct started to get big and his billy rose. And so when he came back, his liver wasn't functioning well enough for me to treat him. And so I thought, is there something that we can do? I can't interrogate the biliary tree, right? Because then my risk of infection is higher. But is there a way that I can interrogate it without causing sort of the least amount of problems? So we did this sort of rendezvous procedure, which is where the GI guys come from below and I come from above, and we met in the middle. And we were able to stent the bile duct above the intestine, right? Because I don't want the intestine to communicate with the bile duct, because that's when it gets bad and there's infection that can go between both, or bacteria that can go between both. And there you can see the stent is going in. We got his total bilirubin down, which means that we were able to get his liver cooled off because it didn't like that it was plugged up. We were able to go back and do a radioembolization, and he again was able to walk his dog and did quite well after that. He ultimately succumbed, but was able again to get out of his house and sort of be part of society. So what I will leave you with is that we are very good at treating patients that have liver-isolated disease in the appropriate setting. Okay, and I will say that again, in the appropriate setting. For symptoms, if patients are having symptoms, we have a 70 to 100% ability to control your symptoms. So if you're having flushing and bad diarrhea, think about that guy. He couldn't walk around the block. Now he went to Walmart. Like, we are very good at getting symptoms because the symptoms come from the tumors that are in your liver, right? If the tumors are below your liver, the liver is going to filter it out, and you're not going to be symptomatic. But if it's in the liver, we're very good at it. Our 5-year overall survivals, you can see there, are excellent. Doesn't matter which therapy, we don't know which therapy, but certainly we should think about it. So liver-directed therapy has shown to benefit patients with metastatic neuroendocrine. As of today, there is no difference among the embotherapies. Maybe tomorrow there will be. We do know that if your doctor is offering you the drug-eluted bead, you should run and say, no, thank you. I will have something else somewhere else, or can you do something else? According to the NCCN guidelines, there's no data to say that you cannot get PRRT in combination with radioembolization or any of the other liver-directed therapies we do. There is early data to suggest that PRRT, again, can be given safely together or in sequence. And just remember that if you have disease outside of the liver and it's isolated to one place or 2 places and it's small, we have other things we can do. We can stick needles other places, or there are other creative solutions we can find to your problem. So please keep us in mind if there's something else that's bothering you. And with that, I will stop. Thank you very much.